Okay, we ask Professor Varadarajulu to the floor. He is president of the Orlando Digestive Health Institute and is professor of medicine at the University of Central Florida College of Medicine. He's internationally known for his expertise and research in complex gastrointestinal disorders, especially interventional EUS and ERCP. Shyam Varadarajulu has been the principal investigator of more than 20 randomized trials. He wrote a textbook on EUS together with Paws, which is a milestone for EUS teaching, and therefore, and not only for that, we are very happy to have you here and that you have accepted to travel so far away from.
Oh, thank you. It's such a pleasure to be here, and thanks, Stefan, for having me. So Stefan has asked me to talk about EUS, and there are a lot of things to talk, so I picked up the top 7 topics and try to spend 2 minutes on each. So I'm going to first talk on diagnostic EUS, and there are 3 hot areas on this. One is tissue acquisition. Yes, some small changes with the type of instrument that we use, and then there is what we call a detachable EUS scope. So tissue acquisition has been there for almost 25 years. It's very good. You get a diagnosis in almost 95 to 98% of the patients. And there are 4 biopsy needles in the market. I think Microtech has got a new needle, so that will make it 5. But oncologists are increasingly asking us for molecular profiling. So the 5-year survival rate in pancreatic cancer used to be 5%, but now it's 12%. And it has changed not because of what we do. It has changed because chemotherapy is increasingly getting better. And it is targeted chemotherapy, so they want more tissue. So these days, routinely, when we perform biopsies, we not only get tissue to make a diagnosis, but we also collect tissue so that additional studies can be done. But there is not much data that has been presented, but about 20% of time, the quantity of tissue is inadequate. So we did a very simple randomized trial, looking to see whether 2 or 3 passes is good. 1 pass definitely is not good enough, because if you have a sampling error, 1 is going to be insufficient. So we took patients with pancreatic cancer. Once we make a diagnosis in the room with a rapid on-site assessment, they were randomized to 2 or 3 passes, and what you find is that close to 100% of the time, you will have enough RNA and DNA. And this information is important because if you've got BRCA positive, they don't respond well to conventional chemotherapy. You have to give them oxyplatin-based chemotherapy. If you've got KRAS G12 mutations, then there are new classes of medications to whom they will respond. And if you've got ETV1 mutations, they don't respond well to chemotherapy. They always get metastasis and die. So these patients, probably chemotherapy should not be given. So at least in this study, what we showed is if you use the francine tip needle, and if you use what we call the stylet pull technique for better suction, if you fan the needle and you collect the tissue in formalin, and if it can be processed with paraffin, then this material can be taken away from the slides. You can perform molecular profiling successfully. So there are a combination of 6 things that you need to perform in tissue acquisition to reach 100% positivity with molecular profiling. The second problem with EUS is that occasionally it's not possible to pass the echoendoscope if you've got strictures. And the most common thing is a problem with the cervical osteophyte, or if you've got esophageal cancer, and we tell that, well, if you can't pass a regular endoscope, it's almost advanced disease, so don't do EUS. And oncologists don't agree with it. They want biopsies from metastatic areas and so on. There's only one manufacturer right now who makes a slim echoendoscope, and that is from Pentax. And this is a simple study that will show you why it might be important. So this is a patient who has got a Roux-en-Y gastric bypass. So at least in EUS, in the United States, every single day, we have a patient with altered anatomy for EUS or ERCPs. So here we are doing what we call an edge procedure. So from the gastric pouch, you are accessing the excluded stomach, and you place a lumen-opposing stent, which is the Axio stent. Then we suture the stent at the same session. And then you can drop any scope through the Axios to go into the excluded stomach so that you can do EUS and ERCPs. Your regular echoendoscope will not go through because it's about 14.2 millimeters. Even with a 20 millimeter Axios, it's difficult. But the slim echoendoscope, which is 11 millimeters from Pentax, can be easily advanced. And once you go down, you can perform whatever intervention you want to perform. In this particular case, this patient had obstructive jaundice, and you can see that there's a mass somewhere in the pancreatic head region, occluding the bile duct, and a tissue acquisition can be undertaken quite easily. We use ROSE, or what we call rapid on-site assessment, in our room, because in the United States, patients come with an expectation they will have a diagnosis at the same session. So we use ROSE, and then you can remove the scope and pass a slim duodenoscope or a regular duodenoscope to perform your ERCPs and place a stent in the conventional fashion. So when we did that in 2,000 consecutive procedures, there are 4 circumstances when a slim scope is important. Your Roux-en-Y gastric bypass anatomy in a jaundiced patient, it's indispensable. Second is, if the patient has got an esophageal stricture, and if you want to navigate the scope, a slim scope is useful. If you've got a big osteophyte, usually in an elderly patient, it's difficult to get the scope past the neck region, so it can be useful. If you've got a scope in the distal duodenum, the slim scope can be pushed much more easily than a regular echoendoscope. And finally, in patients with gastric outlet obstruction, if you can even dilate marginally, and this happens usually in pancreatic cancer, then the scope will go. And we found that in 1.1% of procedures, a slim echoendoscope is critical to completely, for a successful exam. A third development is something called an EndoSound. This is a US-based company. They've applied for FDA approval, and this is a probe and a laptop. So you use a laptop with a special software, and you attach this probe to the tip of your gastroscope or a side view duodenoscope. You can just take it anywhere you want. And then here's a video of a patient who underwent a liver biopsy. It's easy to assemble. It takes about 8 minutes. You can look at the quality of the image. It's, the EUS will play pretty soon. It's a reasonably okay image. It has been worked on the pancreas and in the liver. You will be able to perform basic interventions like FNAs and so on. We don't have much experience with things like drainage procedures or RFAs. Only time will tell. We expect this instrument to be approved by the FDA by the end of the year. And this might be a change. The probe is disposable, but I think you can use it for 40 procedures if you want. So how this will translate into the field and have an impact, we don't know. And there's no clinical data right now. So with interventions, I'll touch on a few things. We've got the RFA catheter that has been used from Taewong for quite a long time, and it is based on RFA. Now there's another company called Creo, which is a British company, that has replaced RFA with a microwave, and this is also used for tumor ablation. It's a 19-gauge needle, and you can pass it successfully in the stomach. With the duodenum, it could be a little challenge because of decreased flexibility. And the advantage of a microwave is that it's supposed to cause deeper tissue injury, and it's not controlled by a feedback mechanism. So you have to be a little careful. You can overburn the normal pancreas. We don't have any data about this new technology. Time will tell. But I think before we focus too much on tumor ablation, we have to look back at the type of data that we have at present. There are only 19 studies on EUS-guided RFA looking at 183 patients around the world. And there are 2 kinds of neuroendocrine tumors. One is the functional tumor, which is an insulinoma. The efficacy is about 95%. So, this is on short-term follow-up. Adverse events is about 18%. The most common is pancreatitis. But the problem is, in these 16 reports, 5 out of these 16 reports had literally 1 patient. And in 10 out of 16 studies, the follow-up is less than 1 year. So you're looking at very, very limited data, and developing products with such limited data can be a problem. If you're looking at non-functional neuroendocrine tumors, most patients are asymptomatic. You treat them only if they are symptomatic. And the treatment efficacy is 95%. The adverse events are about 25%. Once again, it's pancreatitis is a primary problem. And if you follow these patients for a longer time, the tumor will increase in size. So we don't have long-term data on what happens beyond a year. Once more, in 50% of the reports, they had only 1 patient, and in 2/3, the follow-up is less than a year. And then you got something like this, where they tell you, your treatment actually with these thermal devices is better when a tumor is less than 2 centimeters. But if you go and look at the oncology literature, tumors less than 2 centimeters don't require treatment unless they are functional. You shouldn't be treating them at all. So I think We are focusing a lot on these devices, looking at very small patients, and this is data collected from the whole of Europe. So if you are looking at 183 patients across 20 countries over 10 years, and this is all retrospective, we have got some problems. The other issue that we are now focusing on is pancreatic cyst, and it's just because we have got so many patients with pancreatic cyst. We used to ablate them with alcohol, but now they use paclitaxel and gemcitabine, and it has been shown you get an equal treatment success rate of like 67% with almost zero complications. With alcohol, you got 22% complications. And when these 67% of the patients are followed up for a prolonged period of time, there's about a 90% durable response. At the surface, this looks pretty good. And then you've got publications like this. You're looking at 1,077 patients. And when you look at these patients with an average age of more than 50, and you do a CT scan or a MRI, 50% of them will have a cyst in the pancreas. You follow them for 5 years, 15% will develop a new cyst, and these cysts will increase over time. And if you look at those 1,077 patients over a five-year period, not a single patient dies of pancreatic cancer. So we do 3,000 EUS in Florida a year, out of which 1,000 are for pancreatic cysts. I did a simple math, and I realized over 5 years we would be spending only in our own center close to $40 million for zero mortality from these pancreatic cysts. But we get increased referrals, and patients want their pancreas to be checked because there's a phobia for pancreatic cancer. So I think our energy should be more directed towards studying the natural biology of pancreatic cysts than to treat these asymptomatic lesions. So this was one of my talks for DDW for state of the art. I think we just need the wisdom to choose the battle that we need to fight. Endohepatology is a hot topic, and I think this is one area surprisingly the hepatologists are encouraging us, not for liver biopsies, but for portal pressure measurements. They tell us that when they refer patients to interventional radiology, they get wedge pressure, whereas with EUS, we can directly get a portal pressure. And in this particular case, this is the portal vein, the intrahepatic vein, which is very easy to target. And then you puncture it with a 25 gauge needle. This is a transducer from Cook, and you will draw a pressure measurement. And then you retract that needle after an average of 3, and then you puncture the portal vein, and then you calculate the difference. And if it is more than 7, the portal, it's supposed to be positive for portal hypertension. It's a simple procedure to perform. It takes about 10 minutes. The patient should be done under general anesthesia, not under propofol. But otherwise, it's pretty straightforward. And when we do this, we are usually asked to do a liver biopsy at the same time, just because you don't have to repeat this procedure again. But unfortunately, in the United States, I think there are 2 things happening. When you do portal pressures, it's great. You have an added advantage. But we are getting a lot of referrals only for liver biopsies. I think that's, again, a problem, because the cost of an EUS-guided liver biopsy done with EUS, with sedation in the US, is about $13,000. But if you send them to a radiologist with a percutaneous 16 gauge needle, it's probably about $1,000 because they don't even sedate them. So there's a $11,000 difference, but we get lots of referrals because patients don't want to feel any pain whatsoever. So we're doing a lot of EUS-guided biopsies, and the pathologists don't like it because obviously with 16 gauge needle, you get a larger core tissue, whereas with a 19 gauge needle, it is small. So I would call this as the American problem. Like sphincter of Oddi dysfunction, we are obsessed with liver biopsies. But there's good data. If you look at portal pressures, 159 patients, there appears to be a very good correlation between more than a 7 millimeter gradient and presence of esophageal varices, hypertensive gastropathy, thrombocytopenia, and then this is, and when you combine it with liver biopsies, this appears to be a good technique. The next topic is gallbladder drainage. Now, this graph on the left is a very serious graph. So this is the US Medicare database. You're looking at 250,000 patients. So this is real life United States. You can look at the graph in the middle, the curve comes down. This is conversion of open cholecystectomy to laparoscopy, which is good. If you look at the top graph, that is laparoscopic cholecystectomy, it's a stable line. So between the year 2000 to 2010, cholecystectomy, laparoscopic cholecystectomy has gone up by 1.2%. The last graph at the bottom looks very small, but you have to focus on that. That's close to 50,000 procedures. And that has increased by 409%. And this is percutaneous cholecystostomy. So if you go to real United States hospitals, a lot of hospitals, unless the patient is extremely healthy, you come at 1 o'clock at night with pain, you got a little bit of cholangitis, they get a percutaneous cholecystostomy tube. And then they go home, and then they will either have a cholecystectomy at some point if they are very comfortable, or they will get these tubes changed in and out. So I got a patient maybe a couple of months back, and I looked to see when he had his cholecystostomy placed. It was placed August 15th, 1987. So this guy has been having his tubes changed for the last 40 years. So now what we do is EUS-guided gallbladder drainage. So when this patient came, I thought, well, I'm just going to change to an EUS-guided gallbladder drainage. And then I asked my surgeon. He said, no, I can operate on this patient and so on. So EUS-guided gallbladder drainage is a good technique. So this patient has got an emphysematous gallbladder. You can see there, it's coming out. The patient was sick. I can drain this gallbladder. It takes me 10 minutes. But the problem is, if a majority of these can be accessed through the duodenum. So if you put an access through the duodenum, you're converting a cholecystectomy usually into a Whipple procedure, because the surgeon tells me that is an area I can't touch. So most of them will never have surgery. They will sit with this thing, and then you go back and you put a plastic stent, and then you start removing stones, you start having complications, and it is no fun working through the duodenum. You put it through the stomach, it's okay, but then you convert a laparoscopic cholecystectomy into your open cholecystectomy, and I never knew it was this difficult, because one day I went to the parking garage and I saw this surgeon who was about 55 years old after a lap chole with his head all sweating. And he told me, what the hell did you put in the stomach? And my open cholecystectomy of 15 minutes became 2 hours. And surgeons are more and more doing these procedures. I think Boston Scientific is applying for an FDA approval for EUS-guided gallbladder drainage. It will be performed more, but I think we need to take a step back. Yes, we can do it, but are we doing the right thing for the patient? Because at 1 o'clock at night, most patients look as not a surgical candidate because they're sick. And then what you find is that once their sepsis goes down, they're pretty comfortable, and you can always do an elective procedure. So this is a multi-dimensional problem. So I would not say a high-risk surgical patient. EUS-guided gallbladder drainage should be done in what I call a never surgery patient, high COPD patient, extensive coronary artery disease, not ready for heart transplant, pancreatic cancer patients with metal stents who develop cholecystitis. I think this is the patient population we should focus on, which will decrease the indication to literally less than 0.1%. Otherwise, this will be an abused technique. And the last is, this is a simple topic, pancreatic necrosis. Of course, if you have an infection, we have got a 20% mortality. But the problem in pancreatic necrosis, once again, is that when you develop severe acute pancreatitis and pancreatic necrosis, most mortality happens within the first 10 days. We don't even see these patients. They've got acute sepsis and they die. They don't have a fluid collection and they are in the ICU. Should they survive that time, then they have the second hit. When they develop infection and they become septic, they develop multi-organ failure, and there's another 10% mortality. If they survive that, then you develop walled-off pancreatic necrosis. That is when we usually intervene, when mortality is significantly less. But we never go and see the patient when they are in their acute phases of illness, because they really don't even have a fluid collection, or it is ill-defined. So if you look at a time graph, this is your ICU patient within the first 10 days. It's got an ill-defined collection. Nobody wants to put in a drainage catheter, including the radiologist, and this is where maximum death happens. If you wait for 2 weeks or 3 weeks, you've got a collection. It's ill-defined. This is called the acute necrotic collection. I think we can intervene in these patients. There's more and more data, but not robust data. And if you give it time, for 4th week, you've got walled-off necrosis, which is what we treat right now. If you really want to improve outcomes for this patient, we need to be looking at the time frame in the middle, 2 to 3 weeks, what happens there. And if you look at the studies from the Dutch pancreatitis study group, once again, endoscopy is associated with a less pro-inflammatory response and better outcomes for patients. And if you look at Pointer trial, where they have told us there's no advantage in intervening early, but when the Dutch pancreatitis study group tells us early, and you look at their supplemental file, it's usually a third week. It's only at the third week they are putting in a percutaneous catheter. At least in our clinical practice, we are now intervening between the 2 and the 3 week time frame. So I strongly believe that if a patient is very sick, and if the patient is very septic, and if they are unstable, we should be able to intervene in this time frame. Because if you don't do anything, they have a 25% mortality. If you do something, maybe we will have a good outcome, and we can make a meaningful difference. So I think we will see a lot of research going into this area. Also, percutaneous drainage catheters, it is not published data, but when we look at the Medicare database, we realized percutaneous catheters are an independent predictor of mortality. I never realized it. So this is new data that we are hoping to get published, looking at tens of thousands of patients over the last 20 years. So this was my last slide, and then there's another conference. There's a lot of conferences these days. So if you want to step out of Europe, please come to Orlando and see us. Thank you.
Thank you very much for this brilliant lecture. We have learned a lot, and let's hope we can fly to Florida. Are there any questions from the floor? Yes, please.
Thank you very much for this excellent talk, Shyam. I have a couple of questions. The first one is, when you do the edge procedure, I saw you put a suture. Do you do this because you directly use the access immediately, or do you always put a suture and then access a few days later?
So the reason to, if you don't want to suture it, you have to come back after 2 weeks so that the tract is mature. But in the United States, you'll be out of business. I mean, our patients expect things to be done then and there. And if they come with jaundice, they want a tissue diagnosis, they want their procedure the same day. So that is the reason to suture it. If you don't suture it, the stent will almost always migrate. Almost always. And then there is, if it migrates into the retroperitoneal cavity, then you need to have a laparoscopic surgery at that point. So that's the reason we suture at the same time.
Okay. The second question was regarding the peripancreatic collections. When you do early drainage, do you always use axios lambs, for such procedures, or?
Of course. Okay. It's only $5,500. Yeah, we always use lambs. That's the only one that's approved in the United States. But I don't think anyone in the United States anymore uses plastic stents. In fact, people have forgotten how to do plastics, how to use drainage with plastic. So it's always lamps.
Thank you.
Shyam, thank you for this fantastic presentation for the moment. I think you explained very well. We experienced somehow an explosion of non-indicated niche indications. And my question to you is, you talked about the problem of pancreatic cysts. And thank you for citing the German study. What do you think, how do you see this in the future? I think you mentioned that almost this cyst follow-up collapses our healthcare system. When do you see an indication to treat endoscopically with alcohol or anything else, such a cyst in the pancreas? I
mean, I think the problem is we are approaching pancreatic cyst with the eyes of an endoscopist, and I think that is the problem. There are four issues here. Low-risk cyst, low-risk patient. Don't do anything. Low-risk cyst, high-risk patient. There's no point doing anything. High-risk cyst, high-risk patient. They're going to die. Don't do anything. High-risk cyst, low-risk patient. So if you stratify, the 1,000 patients come down to literally 100. You've got a 50-year-old patient with a 3.5 centimeter cyst on the pancreas with a large mural nodule. You need to operate. Guess what happens? You don't have competent surgeons. So they will look at it and say, well, let's get another EUS in 6 months. Let us know what happens. You keep following this guy at age 69. Now he's got a 5 centimeter cyst with a high-grade dysplasia, and he will not get surgery. So one of the advantages of Europe is that you have a concentrated, your outcomes to few specialized centers. Maybe, maybe not. But for us, we have a surgeon in every hospital who claims they can do a Whipple. So, and healthcare systems do not reward us for sending patients to other campuses. We have to preserve them within the system. So this is the problem. The only way we can overcome this problem is to look at the biology of the cyst and risk stratify. Then I think we will do what is right. As I've told you, Stefan, my math tells me in the year 2025, the state of Florida will spend $56 billion on surveillance of pancreatic cysts. And if you translate that, only 5 patients will require a curative Whipple procedure.
But the problems are the guidelines, because I think there are 4 societies, 4 guidelines, and when you look in, you get shocked because you have to follow up either MRI or EUS every 6 to 12 months. So how can we approach this problem with the guidelines?
I don't think guidelines. I think what we need is a longitudinal follow-up after a baseline good characterization, and just chill out for 10 years and collect the data and find out what happens to which patient. Then I think we'll get an answer. Until we don't know what is happening with the pancreatic cyst, we are like blind people trying to figure out how an elephant looks.
Shyam, thank you for this outstanding lecture, and we have now a coffee break of 30 minutes, and I'm looking forward to see you back. Thank you.